Hi everyone, welcome to today's presentation on ASAM criteria. This is the American Society of Addiction Medicine's guidelines. We're going to look at two different elements of ASAM. The first is going to be the actual dimensions that we use to assess clients, and then we're also going to look at the specific levels of care where we place clients. So first of all, the dimensions of treatment are basically 6 different categories on which we assess clients. What we're doing is gathering information during the assessment process, which then guides what level of care we would recommend for a client. So what we're using here is a biopsychosocial, or sometimes called BPS, model of assessment. It's a great holistic way of looking at a client's background and trying to gather information and make a good clinical judgment about what type of care they need. So a way to break down those 6 different dimensions is to think of each of those areas, bio, psycho, and social. So the biological dimensions really are referring to 1 and 2 on the ASAM dimensions. Dimensions 3 and 4 are going to be looking at psychological issues. And finally, dimensions 5 and 6 are referring to social dimensions for the client. So starting off with dimension 1, which is one of the biological issues. The name of this is acute intoxication or withdrawal potential. So here we're assessing whether the client is currently intoxicated, when the last time he or she used was, and how much that's interfering with their functioning and what the risk is of intoxication. So that will partly be based on the severity of the symptoms as well as what type of drug they've used. We know that with drugs like alcohol and benzodiazepines, chronic use can actually be fatal during the withdrawal process, and so that may need to be medically monitored. So we also want to know if there's any history of withdrawal, if they've experienced seizures or other type of withdrawal experiences. How often are they using, how frequently, how much? All of those issues are going to be relevant here. You're also going to have to physically observe whether you see any signs of withdrawal. And if you do think that detoxification can be done safely in what's called an ambulatory setting, so that means non-medical setting, you want to be sure that it is medically safe, and if you're not sure, to check with somebody else to verify that, either another colleague or if there's a physician available. So with certain drugs, we probably, if they've been chronically using, we're probably going to recommend some kind of medically monitored withdrawal. But in some cases, it's not necessary, so you want to be able to make a good judgment there. In dimension 2, we're still in the biological section. We're looking at general medical conditions and complications, anything that's going to affect the type of treatment the person's going to receive that could possibly be an issue that needs to be addressed. So you want to make sure that any medications, any medical history is identified, and find out whether they're stable in those categories, whether they need additional support, and how much that needs to be monitored in order to make a good recommendation for what type of treatment they're going to receive, and also to make sure those medical issues are being addressed throughout their care. Getting into dimension 3, we're now looking at psychological issues. So the title of this is Cognitive, Behavioral, and Emotional Conditions. So here we're asking whether there are any current mental illnesses or if there's any psychological or behavioral problems that will need to be addressed, or they may create a risk or complicate treatment. So if you think about the intense kind of environments that might be experienced in a residential setting where clients are living together, there's certain clients with history of behavioral problems or cognitive problems who would not be appropriate. That environment would simply be too intense for them to function successfully, and so we want to be very aware and cautious of that. So we want to know what those conditions are and how they're going to affect treatment, as well as how we're going to address them in the treatment environment. Evaluate the person's mental health and mental health status, and then find out how well they function. When you talk about activities of daily living, that's, can you take care of yourself? Can you get dressed, feed yourself, get transportation, all those kinds of things that we might take for granted as activities of daily living, but you want to evaluate where the client's at in those dimensions and how well they're actually coping with those. So somebody may have a mental illness or a history of cognitive problems, but maybe they've addressed those, they're coping with those in some way. So you want to evaluate their level of functioning. Dimension 4, still in the psychological category here. we're really looking at readiness to change. So how motivated is the person? What's driving them to receive services? Are they being mandated into treatment? Are they willing to cooperate with treatment? Or do they feel like they're being forced to be there? You also want to look at what the client's actual stage of change is. So that would be, are they in pre-contemplation, contemplation, preparation, action, or maintenance? So at the very bottom where you see PCP-AM, you're trying to figure out and assess the actual stage of change, what their goals are, and what their willingness to participate in treatment is. Now getting into the final two dimensions, which is the social category. Dimension 5 is looking at relapse and continued use potential. One of the things I think of here is after this assessment is done, if the client leaves this office and goes home and leaves our agency, what's going to happen to that client? What's the most likely outcome? Are they immediately going to go and relapse? Are they returning to a high-risk environment with a lot of triggers? Does this person have any kind of support or coping skills in order to deal with any high-risk situations? So you want to be evaluating all of those in this dimension. Is there immediate danger of distress and continued drug use? And finding out what the client in terms of relapse triggers and ability to cope with that as well. Finally, dimension 6, the last social category. This is the recovery environment. So very closely related to dimension 5. What is the client's family situation, living situation? Is the person living in an environment, either the immediate home or surrounding neighborhood where there's easy access to drugs, where maybe it's in the home or other people are using around the client? Do all the client's friends also use drugs or engage in criminal activity that's going to complicate treatment and complicate the recovery process? What's the person's educational and vocational situation? Are they working or are they in school? You also want to look at legal issues, and if there are any other community supports or social service agencies involved in the client's life right now. A couple other big issues that we often overlook at the very bottom there: transportation and childcare. So sometimes we make good referrals to treatment, but it's for a very hard to reach program that might be far away from somebody who doesn't have access to a car or good public transportation, so they can't physically get to the site all the time. Or if somebody's taking care of a child and doesn't have resources to look after their kids, they're going to have a really hard time showing up in treatment if they don't have childcare. So those are the 6 dimensions, and that's part of the assessment process and getting a real good feel for what's going on with the client. Once we've gathered that information, we can start to formulate a picture of where the client's at and what services they need and what the appropriate level of care is. So in addition to those assessment dimensions, ASAM also has us look at what level of care matches with that assessment. So as a clinician, you're actually making a determination about the appropriate level of care. And then you're also evaluating that on an ongoing basis. So initially you might think they need a certain level of care, but we're continuously evaluating whether that's still the appropriate level of care. We're making adjustments as needed. And so always remember, assessment is an ongoing process. It's not something that just happens in one day or one session. It's ongoing throughout treatment. So here are the different levels of care, starting with level 0.5. This is the lowest level. This is sort of the very introduction into the process. It's called early intervention. It consists of basic risk education. Typically, you might see this done at a school, like a college, for example, or some DUI providers do an early intervention stage. The client at this stage doesn't meet criteria for a substance use disorder. So they may be early on in their drug use history, or they may have had some kind of consequence related to like drinking and driving, but it was a first incident and they otherwise don't meet criteria for substance use disorder. So this is to try to raise awareness of a problem for the person. Often consists of a group meeting a few times to try to provide some education and awareness raising. Level 1 is called outpatient services. For adults, this is less than 9 hours per week, and for adolescents, less than 6 hours per week. This also consists of group counseling where you're discussing recovery and motivational enhancement strategies, trying to look at ways to avoid future problems with the behavior. In level 2.1, we have intensive outpatient. So we had outpatient, now we have intensive outpatient. So this is 9 or more hours per week for adults, 6 or more hours per week for adolescents. In this case, ASAM is identifying multi-dimensional instability. So that means there's issues in more than one of those 6 categories or 6 dimensions that we looked at. And so there's problems in at least a couple of different areas in the person's life that need to be addressed and stabilized. At level 2.5, it's a little more intense. So you notice as we're going up here, we're getting higher in intensity level and treatment services. 2.5 is called partial hospitalization. You'll sometimes hear people refer to PHP or partial hospitalization program. This is what they're talking about at that level. Here they're doing 20 hours or more per week of treatment services. Usually what you're looking at is a client attending a hospital or clinic setting for day programming, several days, often 5 days per week, and they're doing multiple hours of programming per day, attending different types of group, therapeutic activities, recreational activities, and they're doing that on site throughout the day. But at the end of the day, they do go home to their own house once programming is done. Now in level 3, we're talking about residential levels of care. So level 3.1 is a low intensity residential. These would be our halfway houses and our recovery homes. They do require that there's 24-hour staff available. So some type of hired clinical staff, for example, a CADC who lives on site and is available to clients. At these levels of care, clients are a little more independent. A lot of times it's used as a step down from either incarceration or from a higher level of residential treatment, where clients have a stable living environment and they have access to supportive services with some group programming. Often they're going to work, paying some rent for the house, following group rules, attending 12-step meetings, and doing drug tests on site. Then at level 3.5, we're looking at high intensity residential. So these are longer term residential programs. For example, the 28-day programs that you might be familiar with. Here there's 24-hour care. There's trained staff at all times on duty. In order to be placed in this level of care, remember when we were talking about dimension 3 with cognitive, behavioral, and emotional issues, you have to evaluate and be sure the client can tolerate this intensity. Remember, this is high intensity residential. So there's always going to be clients, there's always going to be staff around, there's groups kind of nonstop throughout the day. It is a milieu approach where the community and the group itself is providing some level of therapeutic support. And so a client has to be able to tolerate that and interact successfully with peers in order to stay at this level of care. Finally, level 4 is our medically managed intensive inpatient. So this is actually a hospital-based setting where you have 24-hour nursing care. Physicians are available every day, if not 24 hours per day. This requires, in order to stay at this level of care, doing a daily continued stay review. So every 24 hours, we'd be required to do a new continued stay review to evaluate whether the person is still appropriate here. So this person would have substance use issues as well as medical issues that needed to be monitored until they were ready to step down to a lower level of care. A couple of things to note. As far as severity, when you're assessing how severe things are for somebody on the different dimensions of the assessment, somebody who's generally low severity and has minimal current difficulty in most of the areas and their acute or chronic problems are mostly stabilized would be most appropriate for an outpatient setting, that level 1. Somebody who kind of falls into a medium severity with moderate difficulty and impairment, some difficulty coping, but they are able to function if they have clinical support, that person probably falls into level 2, which is IOP or the partial hospitalization program. And then a high severity would be somebody who has more severe difficulty or impairment, who has poor ability to cope with their problems. This person would be looking more at a residential or a hospitalization setting. So that's one way to conceive of turning that assessment and those dimensions into an actual recommendation as far as level of care. If somebody needs detoxification, they can of course do that in a hospital setting, but technically we can assign that to any level of care. So if somebody is a little more stable and you're not as concerned about the risk for withdrawal, but they still need to go through some detoxification period, you can still technically recommend level 1 or level 2, but making sure they're medically monitored during that time for safe detoxification and withdrawal. And then there's a special designation for opioid maintenance therapy programs. And this is where you're using either methadone or Suboxone in addition to case management and other clinical support in order to help somebody who has an opioid addiction. These are actually very solid programs that, in addition to providing a pharmaceutical or medication-assisted therapy, are providing wraparound support and services to connect somebody with counseling, case management, any other medical services they might need to help support their recovery process. All right, I hope that helped give you a good sense of what ASAM is all about, both in terms of the ASAM dimensions of assessment and the ASAM levels of care where we place somebody or recommend somebody into a level of treatment.